So continuing on with our project where we're considering motion as the central part of our semantic network or our network of meaning when looking at anatomical regions or anatomical structures, we are now considering pelvic extension. So to touch briefly on why I'm using the term pelvic extension instead of the more common terms of pelvic tilt, in this case it would be an anterior pelvic tilt or innominate rotation or pelvic rotation, it is mostly on account of the fact that there is no consistent observable information that suggests that the pelvis moves in independent halves or that the pelvis will move on its own. So the term anterior or posterior pelvic tilt are really descriptors of an observation as opposed to how the movement is generated. So what I'm speaking more so about here is how the movement is generated, the locations from which it would be generated. And I also freely note that I am breaking with the consistent osteopathic discussion around the rotation or the movement of one side of the pelvis in relation to the central portion, so in relation to a still sacrum, or in relation to the other half of the pelvis. So I'm not necessarily discussing it that way, understanding completely that this is not consistent with osteopathic or manual therapy tradition or current discussion. So I am breaking with that very much on purpose, and the rationale being that the generation of these motions does not occur in the pelvis, and that the motion of the pelvis in relation to its other half or the other side does not seem to be consistent with the discussion that is had in the profession currently. So I'm having a different discussion, trying to set up a different semantic network or a different network of meaning, very much on purpose. So our main objectives here, specific discussion of what pelvic extension is, what I'm terming it anyways, general discussion of the muscles that extend the pelvic region, general discussion of the nerves that supply those muscles, general discussion of the vascular supply to those muscles, very superficial discussion of the male reproductive system, and then a general discussion of the areas to assess and treat should pelvic extension issues be suspected or reported. So we do our quick overview of planes, sagittal plane, 50% cut of the body left to right, horizontal plane or transverse plane, 50% of the body, 50% cut of the body top to bottom, frontal or coronal plane, 50% cut of the body front to back. Now, motion, generally speaking, within these planes is about an axis, and the axes are perpendicular. So if we're talking about extension, we are talking about bending to the back in the sagittal plane about a transverse axis. So it is posterior rotation about a transverse axis in the sagittal plane. We can use lots of different words to describe it, but it's bending backwards. So in this case, pelvic extension is the approximation of the posterior aspect of the pelvis to the posterior lumbar region. So it's basically the back going to the back. So it would look like backward bending from above, or if you somehow kept the torso somewhat still, the pelvis would rotate upwards or approximate to the lumbar region. Now, the muscles that are going to generate posterior motion of or posterior rotation as a unit of the pelvis in the sagittal plane about the transverse axis are going to be lumbar extensors or extensors of the vertebral region. So you're talking about your spinalis, your longissimus, your iliocostalis. So you're considering that a large portion of the lumbar region is really more occupied with the connective tissue, so with the thoracolumbar fascia, such that some of the muscular contraction may be higher up. It may be in the thoracic region. As far as those more superficial muscles are concerned, then you're considering the more reflexive muscles, or the muscles that are more reflexively controlled in the interspinous, the intertransversarii, the rotatories, and the multifidus rather. So instead of another inter, it's the multifidus. So those muscles will also contribute to movement of the back to the back, or the lumbar column approximating with the posterior side of the pelvis, or the posterior side of the pelvis approximating to the lumbar column. Again, we're talking about it this way so that we understand where the movement is generated from, as opposed, because the pelvis doesn't move independently, it doesn't move itself, as well as it doesn't move somewhat independently one half to the other. So we're considering this as a unit. And the pelvic extension may as well be termed lumbar extension, because that's really the movement that would generate the approximation of the posterior side of the pelvis to the posterior side of the lumbar region. Now, the nerves that are going to supply these muscles are the dorsal, primary, Rami. So they come out of the essentially the back of the spine and run back around to supply sensation and motor tone to the essentially either side of the spinous process. So a very narrow area adjacent to the vertebral column. And that nerve is going to be consistent the whole way through. So it's going to be essentially named for whatever level you're looking at. So whichever section of muscle, be it spinalis, iliocostalis, or longissimus or any of the deeper muscles, the nerve is going to come out of the corresponding segment, right? So it's going to loop around right there. Now, the lumbar arteries and veins are the supply and drainage to the intercostal muscle, or sorry, to the erector spinae in the lumbar region. So these are going to send, just as the intercostal arteries and veins have the posterior portion, which will supply and drain the erector spinae and the deeper muscles in the region of the thorax, the lumbar arteries and veins do the same thing. They supply and drain that region. So if you're looking at the lumbar region and the muscles there on the posterior side or on the lateral side of the spinous process, what you're looking at is lumbar arteries and veins for supply and drainage. So again, this is the same as lumbar extension, the same considerations. Now, very, very superficially, as I noted, we're looking at the male reproductive system. Now, the thing that we really want to look at here, as opposed to with the female reproductive system, we're not considering so much the peritoneal folds or the ligaments. We're considering the muscles in this case, because the male reproductive system is somewhat more dependent on temperature control, as the testicles are outside of the body wall. So the anatomy that we're going to concern ourselves with more is going to be the temperature regulating anatomy, which is the cremaster and dartos muscles. So we also want to make special note that the testicular artery is really the gonadal artery and comes directly off of the abdominal aorta, quite high, so quite close to the kidneys. It descends essentially with the ureters. It then is going to become it is the testicular artery, so it descends out of the body wall to supply the region. Now, that said, the dartos muscle is essentially within the superficial skin of the scrotum, and what it is responsible for is either increasing or decreasing the surface area of the scrotum to alter temperature, as sperm production requires a fairly tightly controlled temperature. Now, the cremaster muscle is essentially an extension of the internal oblique muscle. And as such, what it's going to do is either going to raise or lower the testicles in relation to temperature control or temperature concerns, such that sperm production is maintained. So what this then does, at least with respect to the cremaster muscle and the innervation of the cremaster muscle, which is high in the lumbar plexus, what you're going to be at least attempting to consider if there is any complaint of reproductive function in a male, the thing that you're most likely to be able to respectfully interact with as a hands-on practitioner that does not have the legal capacity to work in those regions directly, whether it be a male or a female. You don't have the legal capacity to work in the vaginal or the penile regions, so you stay away from them. So your general assumption or your general relationship is going to be mechanical correlates to health and disease states, such that at least with respect to the cremaster muscle, if there's a lumbar dysfunction or a lumbar motion restriction, there may be some impact to either the testicular artery or to the cremaster muscle itself. So what you're considering is the motion of the lumbar region as possibly relating to these things. So you look at that region and you assess for motion dysfunction. If it happens to relate, you find out after, because the complaint would change subsequent to the treatment. And when the complaint changes subsequent to the treatment, this is a general statement, then you gain confidence that your prediction or your hypothesis was correct. You don't gain proof, you gain confidence in that concept. But again, the primary thing that we're considering with respect to male reproductive anatomy is the temperature control system in the dartos, which is very superficial and increases or decreases the surface area of the scrotum, essentially for temperature regulation, as well as the cremaster either raising or lowering the scrotum or the testicles for temperature control to maintain temperature for sperm production, as well as other physiological things that will happen within the testicles themselves. So as we are, and then, yeah, so we've already talked about the cremaster and the dartos. So the cremaster you can see on the side without the veins. I don't know necessarily, I'm somewhat confused as to how to flip my orientation to speak to the screen properly, but on the side without the pampiniform plexus, what you have, you can see from the internal oblique, the cremaster descending to basically be able to lift or allow for descent of the testicles. And then you can see within the scrotum, and the superficial fascia in that cut, you can see that the dartos is there to either increase or decrease the surface area with respect to the scrotum for temperature control. Then we're considering also in this region the pudendal nerve. So the pudendal nerve is going to primarily provide motor control to the pelvic floor, as well as sensation to the external genitalia in both males and females. So the pudendal nerve is going to come out of the pelvis. It is going to come medial to the ischium, and then through what is called either the pudendal canal or Alcock's canal, and it is essentially superior to the ischial-rectal fossa. So the area between the ischium and the rectum is a fat-filled region called the ischial-rectal fossa. It's like the hole between the ischium and the rectum. It's not really a hole, but it's an area that's filled with fat. So it protects to some degree the pudendal nerve in either the pudendal canal or Alcock's canal, depending on the term you prefer. But that's going to supply neural tone to the pelvic floor primarily, as well as to the sensation to the external genitalia in both males and females. But the other thing to consider is that within the pudendal canal or Alcock's canal is you're going to have the pudendal artery and vein. So blood supply to the pelvic floor and blood supply to the external genitalia is going to come through that region. What I will say is that in most cases, as an osteopathic manual practitioner, you're not going to be in a situation where you truly need to interface with the ischial-rectal fossa or Alcock's canal on account of the fact that there is not necessarily a large amount of motion, so there's not necessarily going to be a large amount of motion dysfunction. And the treatments that you can apply to the hips and to the lumbar region are likely going to take care of most of the large motion dysfunctions that would cause changes in the pressure environment within the pelvic region. So you don't have to go here, but if you are going to consider it, then what you're going to consider doing is landmarking the ischium and then using your eyes very, very carefully to make sure that you're not going too medial to interact with the region of the patient's external genitalia. Now, that said, you're also going to need to explain, so you're going to need to get informed consent from the patient, and you're going to need to ensure that at all times they know that they can stop the treatment, because it is a very sensitive area, regardless of who the patient is and what type of permission that they give you or what type of consent they give you. You still need to be very careful. So you use your eyes to make sure that you're not approaching the midline very closely, and you're staying as far away from it. You're staying as close to the ischium as you can. So you landmark the ischium, you essentially go medial to it, and then you'll find the region of the ischial-rectal fossa. Now, that said, again, you don't have to do it almost ever as an osteopathic manual practitioner. And there are other larger concerns, such as the movement of the lumbar column and the hips. But if you're going to do it, you really need to be careful of not getting close to the midline, staying close to the ischium, and making sure that you have informed consent, as well as understanding that even if the patient gives consent, they can remove it at any time. And you should take any light signals as signals that you should probably get out of the region or avoid it in general. But again, informed consent is absolutely necessary. It's working in the region of the ischial-rectal fossa, very rarely required of most osteopathic manual practitioners. There will be exceptions, and just staying away from the midline. Now, our areas of consideration for assessment and treatment with respect to pelvic extension, the erector mass, the lumbar vertebrae, the ribs, and the hips. To some degree, you'd be considering the T-spine mildly, but more so the ribs, especially the iliocostalis lumborum. Your red flags or your reasons not to treat or to refer out. Known fractures or tears is don't treat. Suspected fractures or tears, refer out. Rebound tenderness of the abdominal wall is refer out. Known or suspect, so known aneurysms, don't treat the region. Suspected aneurysms, refer out and don't treat. The other deal, as I noted, at least with the pudendal nerve, if there does seem to be alterations in sensation in the external genitalia or the region of the external genitalia, you need to be extremely cautious. You need to stay extremely close to the ischium, stay away from the midline. You need to have really clear, informed consent, and you have to be willing to stop at any time, because the patient, even if they provide that consent, can remove it, and it is a sensitive region. It's almost something that you will never have to encounter within osteopathic practice, because if there is change in sensation to the genital region, a physician is probably more appropriate, or maybe even depending on the region that you're in, a pelvic floor physiotherapist may be a better practitioner to treat changes in sensation in the region. So those are our considerations for pelvic extension, with the special note that pelvic extension does break consistent discussion within manual therapy and osteopathy of an anterior pelvic tilt or an anterior rotation of one side of the pelvis or the other. I'm speaking about it as a unit because it is not observable with any consistency that there is meaningful movement of one side of the pelvis in relation to the sacrum or in relation to the other side, at least in levels large enough to detect. So I'm treating this as a general unit, or the pelvis as a general unit, and I'm talking about the location of generation of the motion.